Teirstein for about 10 minutes, so we might have some time for
About 15 minutes. She took 20 minutes. I'll try to do this fast, but I'd like to have as much time as Dr. Nora had. Thank you for inviting me. Let's see what the slides are. Try it again. My disclosure of conflict of interest includes being the president of an alternative board, the National Board of Physicians and Surgeons. I am unpaid. I also direct and participate in many CME conferences. I'm a big fan of CME, and importantly, I am a grandfather in internal medicine and cardiology. I am not grandfathered in interventional cardiology, so I have participated in recertification with interventional cardiology. I'm going to start by saying something nice. I fully support initial board certification. In fact, the national board that I'm president of requires it. I'm proud of my 3 certifications and the certifications of all my fellows that I train. I think providing initial board certification is a huge contribution that we should all be proud of, and Dr. Nora should be proud of, and the American board should be proud of. I also think the boards should be content with initial certification and not require recertification. I'm going to start with an emotional appeal. This is one of my colleagues, Dr. Curtis Stennis. When he was our fellow 10 years ago, I nicknamed him Sparky because he had so much energy. And you can see him here, always very enthusiastic, at a CME conference, at a break, discussing questions with members. And then 2 weeks ago, I walked past his office and I saw this. He was depressed. And I took this picture. I said, what's the matter? He said, well, I'm taking my cardiology recertification next week, and so I'm studying. And I looked at what he was studying, and it says, you'll see it's pericardium cardiomyopathy. This guy works in a cath lab around a lot of radiation. There's not a lot of pregnant people there. He hasn't seen a pregnant patient since his wife gave birth 4 years ago, but he has to study this to maintain his board certification in cardiology. He's just bored. And I think this is one of our big complaints. It reminds me of this advertisement, a mind is a terrible thing to waste. So that was really what got me going on this topic. I just don't want to waste my time doing things that aren't going to help me. So we all want to keep up with changes. We all want to be the best physicians we can be. But despite all the apologies, the emails, the discussion about modernizing MOC you just saw, there's still, I believe, no evidence that MOC, the recertification, take-home computer modules improve patient outcomes. The proposed new tests, whether they be secure or take-home, still cannot be tailored to the individual physician practices. The work of MOC lacks meaning, it's busy work, and there is an appearance of financial motivation underlying the MOC requirements. Now, I do not believe that everyone in this room agrees with that, but I actually believe that about 15% disagree and 85% agree, and I'll show you why. But as you listen to people who talk about MOC, you should find out if they're grandfathered, if they've ever participated in it. Because it sounds good on paper, but when you actually do it, that's when the devil is in the details, and it's really not that helpful. Why I say 85% was a paper published last week from the Mayo Clinic. This is just a survey. It's not the best survey in the world, about 1,000 physicians from across all specialties. And if you notice the question MOC, or the statement MOC is worth the time and effort required of me, that was supported by 14.8% of the respondents only. And that was even included doctors who just slightly agree. If you take out the slightly agree, it's only 6.4%. And notice the statement MOC is about generating money for the boards was supported by 2/3 of the respondents. So there's a big problem here. Dr. Nora discussed the data. She's right, there's not a lot of time to discuss this. The data is sparse, it's not very robust, and the data about MOC is often conflicted. There were 2 papers published in JAMA. The first one from the VA found no significant association between MOC and patient outcomes. The second one also found no significant association between MOC and patient outcomes. Dr. Nora pointed out that they did point to a small reduction in cost, but she said it was a 2.5% reduction. Actually, it was a 2.5% reduction in the growth of costs, and it was small. And there were things in that paper that actually went towards the other way. For example, emergency room admissions were higher in MOC required physicians. And that's, there are going to be some variations if you look at enough data points, as you know. And this paper points out the conflicts. The authors, particularly Dr. Hombo and Dr. Lipner, as you see here, are affiliated with the American Board of Internal Medicine. Well, that affiliation isn't, they're actually employed. And you'll see Dr. Hombo there makes, I think it's $400 and something thousand a year. Dr. Lipner makes close to $400,000 a year on the 990. So these are conflicts of interest. I agree with Dr. Nora. That's okay. The board should do their own research, but you should be aware of these conflicts of interest. This, I think, is the poster child for conflicts of interest. This paper was brought to my attention by actually a letter to the editor of the New England Journal that was criticizing a paper I wrote. And this paper says, in general, physicians who are board certified provide better patient care, albeit the results have modest effect sizes and are not unequivocal. So modest effect sizes, that means small. Not unequivocal, that means equivocal. So, you know, and this is written again by Dr. Lipner, which is probably why it's spun a little bit that way. And I thought this was written in the Journal of Continuing Education, but actually it was not. It was pointed out to me later. This was actually written in a supplement to the Journal of Continuing Education that was sponsored by the American Board of Medical Specialties. And you can see Dr. Nora's introduction here about professionalism. And, you know, this is doing your own research and then self-publishing it. And I don't even think there's something wrong with that, but I think you should just be aware of it when you look at data. Be aware of where it's coming from. So there's been a lot of apologies. I think that's a good thing. There's been a lot of changes. I think the changes are for the better. In this case, the biggest change with internal medicine is the elimination of the secure 10-year exam if you do well on more frequent exams. And I think that's better than it was, but I think it's just the lesser of two evils. Should we celebrate the end of the recertifying exam? I say not so fast. The revised program replaces one large waste of time every 10 years with 5 smaller wastes of time every 2 years. There's still no evidence the new MLC program improves patient care. It'll still be a waste of time and money. And it costs $200 to $300 depending on how many certifications you have per year. And this yields a lot of money, $40 to $60 million to the Internal Medicine Board. So think about that when you evaluate these programs. This is the evidence of that, the 990. $30 million came from initial exam in 2013, and $24 million came from MOC, and that was before it was required. It was only required in 2014, so there's a lot of money at stake here. We talked a lot about professionalism. I think it includes, professionalism includes managing conflicts of interest. There are over 200,000 diplomates. That works out, if you pay about $250 a year, that's not that much money, but it works out to $50 million, so there's a lot of money at stake. This, to me, looks like a nice toll booth. The whole idea of reinventing itself is interesting because actually it's self-regulation of the American boards by the American boards. And when I keep hearing the words, the privilege of self-regulation that physicians have, actually this is not self-regulation. This is regulation of the physicians by the American boards, not by the physicians. And I'm not so sure. I'm not so sure that the government would be better, actually. I'm not sure. So when you see alternative plans, ask yourself, is this really going to help our patients, or are we just checking the box to quiet the critics? Does the new plan create an MOC pathway that is a little less time-consuming for doctors while still providing the member board with his annual fee? So I want to move on to something really important, which is insurance companies, because only recently have we become aware of how important insurance companies are in the MOC debate. I was unaware of this until very recently. So Medicare does not require board certification or MOC, but many private payers require board certification in their contracts with providers. Therefore, the major academic hospitals that employ physicians usually require MOC for hospital privileges. Why would payers even care about MOC? A lot of private practitioners are worried about losing their certification because they're worried that they'll lose their contracts. But why do the payers care? Well, it turns out, this will surprise you, but the payers are certified just like us physicians are. And who certifies them? 90% are certified by the National Committee on Quality Assurance. And they require payers contract with physicians who are board certified and do MOC. So I looked into this. I just got to the website. I don't know anything about the NCQA. And it's a private corporation. It's not a government organization. It's not for profit. It was founded in 1990, same year that recertification was required, by the way. And they have these quality measurements that the insurance companies have to fulfill to remain certified. So I looked further into this on the website. It was founded, and the president is Margaret O'Kane, and she's not a doctor, but she has a master's degree. And it turns out she's on the board of the American Board of Medical Specialties, which was shocking to me. And by the way, this is their 990 for the NCQA, and the organization she founded and is president of pays her almost $700,000 a year in 2013. So you really can't make this stuff up. So to me, this is sort of like the musical, The Fiddler on the Roof, right? It takes a village. The payers require MOC because the NCQA requires MOC because the ABMS requires MOC. And the founder of the NCQA is a board member of the ABMS. And what holds this village of fiddlers together? It's tradition? No, it's tuition. It's money. Who are they fiddling with? Well, you know, they're fiddling with us, physicians, and some people call this a medical industrial complex. I think that's going a little bit far. MOC has now gone, and criticism of MOC has now gone mainstream. There are a lot of organizations against it. Recently, even the American Medical Association resolved in this past June to the immediate end of any mandatory secured recertifying examinations. Importantly, Oklahoma legislator signed a law banning forced MOC. And here, let me read. I'm getting close to summing up, but I have 3 more slides.
Let me explain to the House. We have a definite time at 10:35 for our president's speech. We have given our speakers specific times. If you would like to give up Q&A time, that's fine. 5 more minutes.
I will be very quick. Well, I won't take 5 minutes. So that law states, nothing in the Oklahoma Medical and Surgical Licensure Act shall be construed as to require a physician to secure MOC as a condition of licensure, reimbursement, employment, and admitting privileges at a hospital in the state. Now that came from the Oklahoma Medical Association. And so this organization has a lot of power and influence. The CMA and other state medical organizations are key in this discussion. And my question is, how do we get California to adopt laws similar to Oklahoma? What's the best method of overcoming these challenges? I think it might be a law, maybe it's not, but we've got to overcome these challenges and do something positive. And finally, I want to just mention advertisement, because this state, California, and I think only one other state, Texas, has a requirement that you have to be board certified to advertise that you have to be board certified that advertise that you're a board certified physician. You have to be board certified by an American board or one of its equivalents. And many hospital administrators view disclosing board certification on the hospital website as advertising, and therefore MOC becomes required to maintain hospital privileges. I think the California law regarding physician advertising was actually well intended, but was passed when board certification was lifelong, and I think the law needs to be updated to require initial board certification, not MOC or recertification to advertise. So to conclude, my last slide. I think we're really lucky to be doctors. A lot of regulation. It's getting tougher, but I still think it's a great job. A reporter asked me recently, hasn't this anti-MOC activity of yours taken a lot of your time? Wouldn't it have just been easier just to do your MOC? And I thought that was funny, and that's of course true, but the key is this. Doctors in general, we're not lazy. We actually like to work. We just want to do meaningful work. I mean, the problem is we don't believe that doing the MOC is meaningful. So my plea is, let's do something here that's meaningful. Let's pass some strong anti-MOC resolution today, not just studying it further. Let's do something that really changes it and makes us able to practice medicine in this state without having to recertify or do MOC. Thank you for your attention. Thank you. Thank you. Thank you.